Okay, well, COVID series, we have had presentations on all three of these points. Today's presentation by Dr. Bowdish will focus on the physical well-being of older adults or older workers. So welcome again to everyone. We're so excited that you're joining us on the Friday before the long weekend. And as you know, we've invited Dr. Dawn Bowdish to present on managing mixed immunity and related infection risks. It will be up to 1.5 hours. It is being recorded and shared on Facebook, on YouTube, and we'll have a link on our OHCOW website on our Occ-COVID page. We welcome your participation in the chat, and Dr. Bowdish will take a look at that periodically, as will Valerie Wolf, who's our Executive Director and the lead for the Occ-COVID webinars. We want you to know that there will be time allotted for questions both during the presentation and after. And we might also suggest that you leave your camera off unless you are asking a question, just to help preserve our bandwidth. So just by way of introduction, I wanted to show just a couple of slides from the public health website that looks at COVID wastewater in Ontario. These were published yesterday, October the 5th, and I wanted to draw your attention to the far right-hand side here for the 2 weeks between September 13th to September 27th. We can definitely see an upward trajectory in Ontario as a whole in our wastewater, COVID in our wastewater. So it's definitely starting to increase. There are 4 specific communities that I wanted to draw your attention to. One is Northwest Ontario, and if you take a look at the steepness of this trajectory over these 2 weeks, it is a little bit concerning. Again, Eastern Ontario is showing a definite upward trend in that far right-hand side trajectory. Central East Ontario, excluding the GTA, is also showing a very strong upward trend in COVID and wastewater. And lastly, Southwest Ontario, where I live, is also showing a very strong trajectory. So with that as a backdrop, knowing that COVID is starting to increase, I would like to take this opportunity to introduce to you Dr. Dawn Bowdish. She's a professor at McMaster University. She's the executive director of the Firestone Institute for Respiratory Health. She's Canada's research chair in aging and immunity. She's also a co-researcher in Canada's largest study of COVID-19 infections in older adults. And as well, she's a member of the board of directors of the Lung Health Foundation, where she advocates to increase research funding for lung health. I just wanted to take a moment to let you know that she investigates the changes in the aging immune system that makes older adults vulnerable to pneumonia, and how microbes on our body and in our gut help to protect us. And she also looks at understanding why the aging immune system does not respond as well to vaccinations for pneumonia and COVID-19. Please join me in welcoming Dr. Dawn Bowdish.
Thank you so much for having me. It's a real pleasure to be here and to speak to this audience in particular, because obviously this is a group of people who care deeply about the health of both the people that they serve, but also themselves. And I think there's a lot to be learned from the COVID pandemic still. So as mentioned, these are some of my credentials, and here are some of my contact information if you have any questions or if you'd like to reach out after the talk today. Before I begin, I'd like to acknowledge that the Bowdish Lab is situated at McMaster University and the Firestone Institute for Respiratory Health, both of which sit on the traditional territories of the Mississauga and the Haudenosaunee Nations, and within the lands protected by the Dish with the One Spoon Wampum Agreement. I would also like to acknowledge, as part of my personal journey of truth and reconciliation, that colonization of this land has contributed to unequal health in settlers and our Indigenous peers, especially in the context of aging well and in the context of COVID-19. So today's story is really a story that reminds me of this quote from Donald Rumsfeld, which at the time I thought was insane, but now I actually think pretty fairly describes the COVID pandemic. There are things that we know, the known knowns. There are things that we know we don't know, but there are also things we don't know what we don't know. And in today's presentation, I'm going to try to share with you some of the things we definitely know, some of the things we definitely don't know, and highlight some of the things that have been a bit surprising and highlighted that intermediary phase. And I also really want to give you a really fair perspective about how this pandemic has changed and how our knowledge is not keeping up with the variants that are such a challenge in this pandemic. So one of the things I'm going to do is, whenever there's an area that I know the data is not very clear on, I'm going to give you this little warning sign, and this little beacon will tell you that you're entering a zone where we're going to give you what's today's best information, but there are some caveats, and I'll share those caveats with you. So here's what we definitely know about COVID. So we know that COVID-19 infections can have serious long-term health consequences. It's worth preventing COVID infections, not just because it'll temporarily inconvenience you by being sick, but because we really don't understand the long-term health consequences. We are absolutely sure that vaccination protects against these infections, and because it protects against the infections, if you're not sick, you can't get the long-term health consequences. This much the data is crystal clear about. What is less clear, though, is the evolving context of these Omicron variants, the variants that we currently have. All of them are a little bit different. And so one of the real challenges in making personal health decisions and making decisions about how we live and work is that we don't actually have a very clear answer about how well these Omicron variants, how much they cause these same health issues. We also don't have a solid number to state how much vaccination protects us against long-term health issues. And because we don't have this information yet, I, in my personal life and in my professional life, find it really hard to know when everything is going to go back to our pre-pandemic normal. This graph is going to feature heavily. So I show this to you. This is hospitalizations over the course of the pandemic, broken down by age groups. And in all the slides I'm going to show you today, you'll see references where you can get this information at the bottom right-hand corner. Now, if you look at this graph, you will see the terrible first peak that happened primarily in the long-term care population in sort of March to April 2020, those really dark lockdown times. You'll see the second wave, which was actually even more devastating, and a third wave, and right at the peak of which vaccines started being available to the general public. And we had that wonderful summer where things were looking bright. And then we had the Delta variant come through. And one of the things that you'll see here is there's quite a few hospitalizations for sort of younger adults as well. And just as things started to look like they were going to get back to normal, we were going to have a nice Christmas, then we had the arrival of the Omicron waves. And so you can see this enormous increase in hospitalizations to Omicron, and you can see all the subsequent waves there. Because we're going to look at these graphs a few times during this presentation, I want you to see that the gray area, the zone here, means that the final counts haven't been done yet. So these numbers might change a little bit, and you really can't rely on the data that's really fresh because those final counts are not in yet. I'll also share that the reason I show hospitalization instead of cases is because we have so little testing in the Omicron era that showing case counts would really not be really representative of what the data looks like. But in Canada, we're pretty good at detecting the hospitalization, so it's a reasonably fair way to show the data. And then I think the age breakdown, I think, is really helpful because many of us have older adults in our life, many of us are getting older, and it shows just how devastating this infection is. From an immune perspective, we really have to break down COVID infections from the pre-Omicron era and the Omicron era. They were quite different. So you will have heard this word soup that we throw around with all these different variants. In the pre-Omicron era, the virus that we started with, we now call the ancestral or the original virus. Then we had the Alpha variant, the Gamma variant, the Delta variant. And then once we hit the Omicron era, it's alphabet soup. We started with this BA1, BA2, BA5, BQ, XB, blah, 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 and on and on and on it goes. So because it's so important to break this down into these two eras, partially because we as humans have what's called anchor bias. When we hear, the first thing we hear, we hold on to the longest, and we believe the longest, even if the data changes. So many people's perceptions about how well the vaccines work or do these viruses infect kids are sort of holdover from that pre-Omicron era when we were all watching the news, all getting such a barrage of data. And in the Omicron era, things have changed, but because we're not all consistently glued to the TVs because we're all locked up at home anymore, we don't get that same information. So what I'll try to do is break down some of the major differences between the world we now live in versus what we had going at the beginning of the pandemic. So in the pre-Omicron era, COVID was highly infectious, obviously. It was very contagious, much more than influenza, probably about the same as the RSV virus and some of the other cold and flu viruses. In the Omicron era, we have a virus that's extremely contagious. It's much, much more contagious than influenza and RSV. And what this means is the time you have to spend in the same space as someone who's got an infection is pretty short. And this increased infectiousness has really contributed to a lot of the mortality due to this virus. And I just want to point this out because one of the things, as someone who does a lot of communication with the public, if you ask most people, they'll say Omicron is less serious than the other ones. We were told it was less serious. But I want you to look at this hospitalization data and look at how high those numbers are. And I want you to tell me which one's more or less serious. There's this truth in infectious disease that having a disease that kills lots of people, but not very infectious, and a virus that's highly, highly infectious, but doesn't kill quite as many people, the second one kills more because it just infects more people and finds more vulnerable people. So when we look at these hospitalizations and deaths, we find that the Omicron era is far, far deadlier than in the pre-Omicron era. And when we look, we see that we also see a bump up in hospitalization of sort of younger adults. It's not really, although obviously it's very dramatic in the oldest old, even in middle-aged people, there are significant hospitalizations. So I strongly protest the idea of Omicron being framed as a more mild form of the virus. It's so infectious that it kills many more people. And most of that sort of mildness was because it came to people when they already had a backbone of vaccination that their immune system could work with. Now, one of the things that's really weird about the time we currently live in, we had these great sweeps of the virus taking over. When Delta came, it completely erased all the ones before it. With Omicron, within 3 weeks, all the viruses were Omicron. And then this graph that I'm showing here is more recent data, where we had, again, alphabet soup, but we had the BA5 lineages in green there, and then we had the BQ lineages come and take over, and then we had the XBB lineages in the peach color. But if you look at where we are today, which is at that week 36 there's actually quite a few different variants circulating right now, but they're all within sort of a similar family. And so the hope is that the vaccine that is starting to be rolled out even as we speak targets this sort of family and will hopefully provide more protection against this sort of what I call variant soup that we're currently living in. Now, one of the other major differences between the pre-Omicron days and the time we live in now is that how much and how the vaccines protect. When in a perfect world, we all want a vaccine, that we have our vaccine and we never get sick and we never know we're sick. We're completely protected and we don't get the sniffles, it's fine. We envision, because we've been vaccinated with childhood vaccines like measles, we envision that it's going to be like that. But the fact of the matter, especially in the context of adult vaccinations, that's an unrealistic expectation, and I'll talk about some of the data why. So in the pre-Omicron era, you got extremely high protection from symptomatic infection. It's a little bit hard to say what those numbers were because it depends on the variant, but really, really high protection from symptomatic infection. There's a myth that if you get vaccinated today, you won't be protected at all, and that's not quite true. There's some subtleties to that. Certainly, the reason those peaks that we looked at and those hospitalization rates come every 3, 4, maybe 5 months if we're lucky, is because that period of protection gets shorter and shorter with Omicron. There's also a bit of a dose effect. So there was a really clever paper that came out recently that showed if you're vaccinated and you're exposed just to a little bit of virus because somebody who works in the same building with you or lives, in an apartment that's, 5 doors down has COVID, you'll probably be able to fight off that minimal exposure. But if you're living with someone and sharing a bed, or you're tending your sick kid or whatever, and you're in really close contact, you will not be fully protected from symptomatic vaccine. So there's a little bit of a dose effect. So it's not accurate to say it doesn't protect you at all from symptomatic infection, but it does have a reasonably short period. And in a couple slides, I'm going to show you what we know from influenza and how we can expect that to be important. It is important to say, though, people who are vaccinated do tend to clear the virus more quickly and have less virus in them. So if everyone were to get vaccinated at the same time, we would have an impact on reducing the amount of virus in our population. In the pre-Omicron era, protection against severe infection, so this is going to the hospital or dying or getting really, really ill, was extremely high from vaccination. And in the Omicron era, it's also very, very high. But what we do see is there is some waning. So one of the things that troubles me is that many people thought getting the 2 doses of that vaccine was going to hold them through for the rest of their days. Don't think that, because it's not true. And we know that now that the older you get and with the more time, there is a waning. The WHO recommends that we keep 75% protection against severe infection in the population. Now, for me, I want more than 75%. I don't want to go to the hospital. But 9 months seems to be when you hit that 75% for sort of older adults. So you don't want to be more than 9 months out of your last vaccine is what it comes down to. And another big question is, how much does having had an infection, again, people want this to be like chickenpox. I had chickenpox once, I never got chickenpox again. That's not realistic. Most viruses don't work like that. You've had more than one cold in your life. If you're susceptible to like UTIs, you've had more than one of those in your life. Some of you will have more than one pneumonia or an exacerbation of a chronic airway disease. The immune system rarely protects you from infections. Otherwise, all the bacteria and viruses would die out and we wouldn't have infections anymore. So it is unreasonable to expect that having been infected is going to protect you in perpetuity. Now, in the pre-Omicron era, you did get a good period of protection if you didn't have a vaccine with you. In the Omicron era, the evidence that you get any protection from your next Omicron infection is very, very weak. I would not rely on having had an infection to protect you. And now what about this thing called hybrid immunity? And that's when you get the best of both worlds. You have your vaccine and you have an infection, and together, how does that help you? Well, again, in the pre-Omicron era, we knew that you got at least 9 months. And unfortunately, we'll never know how long because that era sort of ended. In the Omicron era, there's a lot of variation here. And I'll show you some of my data with older adults. The real black box is kids, because they tend to have really nice long duration of their immune response. But for most of us adults, it does seem that there's waning every 3 to 6 months. And again, that helps to explain why we see these peaks in hospitalization that come and go at about that same time frame. People, like I said, tend to have very unrealistic expectations of what a vaccine can do for them. And also because childhood vaccines work with an empty immune system that has lots of capacity, and they have a very different way of responding than adults, where we're sort of already locked into how we're going to respond to things. So the vaccine, the adult vaccine that we have the most experience with and is the most relevant to COVID is influenza. Here, what I'm showing you is the effectiveness against symptomatic infection for your flu vaccines. And if you cast your eye to 2010, 2011, that was a great year. You got 60% protection from symptomatic infection. If you cast your eye to either 2004, 2005, or maybe 2014, 15, those are years when the match wasn't very good. And so you didn't get that kind of protection against symptomatic infection. But honestly, 60% protection from symptomatic infection is about the best we can get. And very similar to COVID, though, the real bang for your buck is protection against severe disease. So people who are immunized against influenza are less likely to be hospitalized. If they are hospitalized, we'll have a shorter stay. One of the things people don't realize is how many heart attacks are attributable to having had a serious respiratory infection. Influenza, pneumonia, and COVID are all associated with increased risk in heart attacks. You get vaccinated, you also reduce the risk because the disease is less severe. And I think most importantly to those of us who are either middle-aged or a little bit older is that we want to age well. And people who are immunized against influenza and get sick are less likely to develop what we call a catastrophic disability, a change in their ability to function so much that it affects their daily life. And they remain able to be independent for longer. So even if you only get 60% protection, I think this makes it really worth your while getting vaccinated. So adult vaccines are best thought of as protecting against, serious infections and long-term health consequences. And what's fascinating about the COVID story is we know exactly how these work. So what I'm showing you is some pictures of lungs from somebody who has COVID, taken very early in the pandemic when people did not have a vaccine when they got the infection. Now, a lung should look black. It should be full of air, and air is black. Any white or gray or fuzziness in these lungs, so one's sort of cut like from top down and the other one's sort of like an x-ray. Any white bits means that there's liquid in that lung. And when you have liquid in your lung, you have pneumonia and you can't breathe, and that can kill you. And if you remember at the very beginning of the pandemic, there was a panic about the number of ventilators required. This was because this filling up of the lungs with liquid was so severe that people needed to be on a mechanical ventilator. And what we now understand is that the reason the lungs got so filled up with this liquid is without the power of a vaccine in your immune bank account, people's immune responses were so hyperinflammatory that they caused the lungs to become leaky and fill up with white blood cells and with liquid. But as soon as you got that vaccine, even one dose, your immune system had a template to make antibodies properly. Even if you didn't have enough to sort of completely prevent the infection, you had enough to dampen down this lung inflammation. And so a lot of our belief that Omicron is more mild comes from the fact people don't need ventilators anymore because they have this backbone of protection in them. And so now we've already sort of modulated the disease to make it less severe than it was in those very, very, very grim early days. Now, I told you that 60% protection from symptomatic infection is what you can reasonably expect from influenza. But in fact, there's a 10% decrease in protection every month. And that's okay because influenza season generally lasts about 6 months. But we have to adapt our expectations for COVID, which doesn't follow this pattern. So this is what our standard sort of influenza graph looks like. On the bottom axis here, like week 1 is the first week of January, and then it goes down. In the red, there was no COVID during the 2020, or no influenza during the 2020-2021 season because all our mitigation measures got rid of it. It came back when we lifted a lot of those measures in 2021, 2022. Last year was a weird year where it came a little bit early. But so let's remove all those weird years and just look at the thick gray bars though, because those are sort of the averages of our pre-pandemic life. And what you see is influenza season starts, sort of November-ish, and it kind of goes up, and then it kind of ends by May at the latest. And so imagine if your employer or your pharmacist or whatever starts their vaccine campaign. Generally, for the general public, it's around November, and for those of you who are in healthcare or other related industries, it might be in October. So you get your 60% protection in November, that goes down to 50% December, 40%, 30%, et cetera, et cetera, et cetera. You're still pretty much covered for most of cold and flu season, right? Because it happens to last about 6 months. But you are actually more likely to get influenza at the end of the season than the beginning of the season because of that waning efficacy. So 6 months is at best what you can expect protection from symptomatic infection. And this is exactly the same as COVID vaccination, 6 months or less. So I give you these data because I want you to know what is a reasonable expectation from our vaccines. We cannot demand perfection because perfection doesn't exist in the real world, not for influenza, not for COVID, and frankly, not for any adult vaccine we have. Oops, sorry. So again, I just want to show you this timeline so you can get a sense of this. Now, one of the reasons we know that these peaks come a little bit fast and furious in between, and if you kind of do the math down here, you'll see it's between 3 and 6 months, is because COVID in the Omicron era is so good at evading the immune system that period of protection is less than 6 months. And so what you can see, imagine you got your vaccine, right around here at the start of 2022. You can see that, your 60% protection would maybe hold you through here, but whoops, now here's another peak that's just 4 months later. So this is one of the pieces of evidence we use to understand the timeline which we can reasonably expect to be protected for. And unfortunately for us, COVID comes more than once a year, right? We have not yet since 2020 had a year where there was only one wave. We have multiple waves per year. So it's perfectly reasonable to assume that we're going to need multiple vaccines per year to keep us covered over those waves. And I think, all credit to our public health officials and our policymakers who are trying to make these decisions. The more vaccines we offer, the fewer people take them. If you go once, imagine this fall, you go once to your pharmacist, you get your flu shot, you get your COVID shot, you're done. It's very difficult for people to follow the news, figure out when a wave's starting, figure out where they can go get a vaccine, go get their COVID one, go get their influenza one next year. But the challenge is COVID does not yet follow the same seasonal pattern. So it really doesn't make sense for us to try to push all the vaccinations into the pattern that fits for influenza from an immune perspective. And I also just want to emphasize that in Canada, we like to say, oh, we got lots of people vaccinated. We have over 80% vaccination rates. Awesome, great. That's why we don't need those ventilators so much anymore. But when we look at the percentage of people who've been vaccinated in the last 6 months, it's about 15%. And that also helps explain why we see these recurrent waves, because that period of protection is short. Being vaccinated in 2021 does not a lot for symptomatic infections. In fact, it does nothing in 2023. So when you're thinking about how to best protect yourself, remember you don't want to be more than 6 to 9 months out from your last vaccine. Okay, so that is some of the things we know. Now let's talk about some of the things we don't know. One of the things that puts the fear of God into healthcare workers and to policymakers and to those of us who follow this is we'll have another Omicron-like event where we have this massive, massive surge in infections. And our healthcare system, and many of you work in this system, will speak to the stress of the system. And we cannot accommodate these slightly lower peaks, let alone a massive Omicron-like event. Here's how we try to predict which of the variants are going to be bad. Now, this is a picture of the enemy, the SARS-CoV-2 virus. And in the red here is what's called the spike protein. The spike protein, and specifically this little tiny little area right there, is what binds to us. When we had the original strain and we had our original antibodies, those antibodies bound really, really strongly to that part that binds to us. And so if the antibodies were bound, the virus couldn't bind to us and it was blocked. During the course of evolution, Omicron developed some mutations in this area, and so we don't see such great binding. So when you hear things like it's immune evasive, how we test that is we take the blood from people who've either been vaccinated or infected, and we mix it up with the virus itself and see how well does this stick. And if the answer is it doesn't stick, because there's been mutations here, we call that an immune evasive virus. The next thing we do is we see if that virus can infect a cell. So this is called neutralizing, because it neutralizes the virus so it can't infect us. Again, if those antibodies stick really well to the virus, it can't get in us, we're fine. If the antibodies aren't very sticky, or if they don't bind to the right places on the virus can get into our cells. So when we look at each of these new variants, the first thing, whoever gets the virus first, whoever isolates the virus first, they go out and they collect a bunch of blood from people who've been either recently vaccinated or infected, and they measure these neutralizing antibodies, how sticky these antibodies are, and they make a guess about how bad this virus is going to be. And what I find super fascinating is that these guesses are imperfect. So BA1 was massively immune evasive compared to the Delta variant. So it makes sense that we saw this big wave. But BA2 is more immune evasive than BA1, BA5 more than BA2, BQ, BA5, XB more than BQ, EG more than XBB. And we don't see this massive increase in hospitalization, even though they're more immune evasive. This teaches us a few things, one of which, of course, is humility, a very good lesson for all scientists to learn. It shows that we don't know everything, but it also shows us that there are aspects of our immune response to this virus that we don't fully understand, but help protect us. And one of those aspects, that a known unknown, so we don't really understand it yet, is how are they evading our immune system if it's not strictly due to these neutralizing antibodies. Now, I published a very controversial paper, extremely controversial paper with some of my colleagues, and I want to, again, just orient you first. This was a study of people living in long-term care and retirement communities. Although there was an age range, the youngest person in our LTC long-term care study was 30. The oldest was over 100. They're about 80 was the average. So older people, lots of comorbidities, lots of, health issues and things like that. And we had about 1,500 people at our peak in about 26 different homes, and they were kind enough to give us blood about every 3 months. And every time one of these waves came, we'd say to ourselves, what protected or made people sick? And we would say, could it be how old they were? Could it be how recently they were vaccinated? Could it be the medications they're on? All these things. We found a very, very interesting and strange story during the BA5 wave. So in these 4 groups of people, in the sort of peachy color, everybody was vaccinated. So let me just say that clearly. In long-term care and retirement homes, everyone was vaccinated. We didn't have any unvaccinated people. So that's the same for everybody. What we found is we compared people who just had an infection about 4 or 5 months earlier, who had BA1. We found people who had sort of a pre-Omicron infection, another infection before that, people who'd already had a couple different COVID infections, and people who had never had infections. And then we watched to see who got infected. And what you can see from this chart, that the people who got infected were the ones who'd recently had an infection. And this is the exact opposite about how things are going to work. What's supposed to happen, you get infected, and that gives you a little bit more protection from the next infection. But in this one population, we found that this was the opposite. I can't explain this. It doesn't happen for all variants. It also hasn't happened since then. But that just teaches me that there's something going on between these viruses and our immune system that I can't fully explain yet, although obviously it's an active area of research. So I want to give you the caveats here so you remember this properly. I don't want you to go home and say to your friends and family, oh my goodness, if you get one Omicron infection, you're going to get another infection, because that would not be accurate. Our population is older and sicker than most people. I don't think this applies to the general population, but it's almost impossible to tell because we don't have the same degree of testing in the general population. Until very recently, retirement homes and long-term care, there was all sorts of testing. If you had any symptom, there was a test. If you had close contact with an infected person, there was a test. Sometimes they were just tests to see if there was any hidden infections. And in the general population, researchers like myself don't get to know if you've just had a rapid test turn positive. It's not recorded in your medical records. It's not something you would report. So it makes finding these sorts of associations nearly impossible. And again, we are blessed to have 2 years of data, and we've looked at this interaction with other variants, and it doesn't seem to be the case. So the take-home message here is a previous infection is not always going to protect you from the next infection. And it's important to know that because our current vaccination strategies say if you've had an infection, wait 6 months. In this population, that was not good advice. It's the most controversial paper I've ever published, and I've published some doozies, so okay. Now, I call it news you can use, and the news you can use is the recent statement from our National Advisory Council on Immunization. There is a really important change of wording for this year's vaccines. We are not using the word booster anymore. Cut that out from your vocabulary, no more boosters. And the reason we're not calling vaccines boosters anymore is because these aren't just sort of to give you a little top up of what you've already got. We've moved to a model that's exactly like seasonal flu vaccines. We will continue to adapt the COVID vaccines to the strains that are circulating, the variants that are circulating, and we will all require updates to get the most protection from that. I'm going to tell you a story a little bit later about an alternative universe where this pandemic went differently, but for now, what we need to be clear about is that these vaccines are not a top-up. They are to deal with the most recent one. So I've copied down the wording here, and I won't read it all out to you, but effectively what the wording says is Canadians should all get an updated vaccine. There is a debate between whether a vaccine is a personal health decision that you get to protect yourself, or if it's a public health decision, something you need to do to protect others around you, just like all the other public health rules we have. Getting younger people vaccinated, ironically, probably has a bigger impact on protecting older adults and the most vulnerable than in some cases getting them vaccinated themselves, because fewer infections in the community mean that they're less likely to see the infection at all. Immunization is really important, and I'm just going to highlight a couple of groups that don't get the attention they deserve. People, understand that older adults get vaccinated, and older adults absolutely they're the ones who are running, not walking, to their vaccine clinics. I love working with older adults. They never accuse me of, vaccines causing autism. They are in it to get protected. So that we'll take as a given. Pregnancy, though, is so essential. One of the things that pregnant women often think is that it's safer to do nothing than to get a vaccine. Oh, I'm a little bit nervous about this vaccine. Oh, it may be safer. In fact, we know that if pregnant women get infected with COVID, they are more likely to have a premature birth or complications during pregnancy, and their babies are more likely to be small, which is long-term health issues. We also know that serious illness during pregnancy can lead to neurodevelopmental disorders in the baby. We also know from the terrible season we had last year that if a woman gets vaccinated while she's pregnant, she can pass on that protection for her baby for 6 months. And so many of the pediatric hospitalizations last year could have been prevented if pregnant women were getting their influenza and their COVID vaccine. So if you know or love a pregnant person, please encourage them to get vaccinated. We also know that COVID has taken a disproportionate toll on First Nations, Indigenous, and racialized communities. And so they also are a priority population to remedy this terrible, terrible inequity. Some other highlights that I just want you to see, that you, unless you're a nerd like me who reads the National Advisory, it's 220 pages, so I don't see why you wouldn't, but I'll just highlight a couple of other things that I'd love you to see. You might be asking yourself, can I get my flu shot at the same time? Because it's so inconvenient to get, I know, and especially if you're trying to find a place that has it. So yes, there's no concerns about getting your vaccines at the same time, so that's great news. And the other thing that I'm really happy that they put into this, people look at me and they look at the National Advisory Council on Immunization, and they assume because we're all about the immunization, we're going to say get vaccinated and you're going to be fine. And the answer is no. Vaccination is a tool, but it's not the only tool. So in your official guidance, it says that you should continue to follow recommended public health measures for prevention of transmission. So vaccines are a tool, but they are not going to be the end all be all. And I would never say otherwise. I see that there's a comment about the nonprofit versus profit in Canada's healthcare, and I will actually address that in a couple slides. It's an excellent point. Okay, so here's another thing we know. And, you know, in my pre-COVID life, I used to study serious respiratory infections like pneumonia in older adults. And I used to go around and tell people all the time that your vaccination is not just about the acute infection, it's about the long-term health issues. And I used to do all these lectures and I felt like I was screaming into the void. I am still screaming into the void. And I'm going to say this as simply as I can. Serious infections are bad for you. They're bad. And I'll give you some data to support that statement. There is no such thing as a serious infection that's good for your immune system. I present to you as evidence two very famous pieces of art. On the left here, we're seeing Edvard Munch, who's famous for the Scream guy. He actually had effectively what we would now call long COVID, but long pandemic influenza after he had the Spanish flu, or what we call pandemic influenza now, in 1919. So there was a syndrome similar to long COVID where people were unhealthy for a really, really long time, sometimes years, and he suffered from this, and this is his self-portrait. The other thing that serious respiratory infections can cause, especially mostly in the context of influenza, are susceptibility to infections that come afterwards. So this famous picture on the right, The Kiss by Gustav Klimt, you know, was on my university poster in my university dorm room. He actually died of post-influenza pneumonia. So he survived the influenza, but he died of the pneumonia that followed it. So serious respiratory infections can cause long-term sort of chronic health issues, and they can also sometimes contribute to subsequent bacterial infections. I will say that COVID-19 is a big outlier in this domain because it doesn't seem to cause that post-COVID pneumonia in the same way that influenza does. So like I said, in my previous life, screaming into the void, telling people why they should get vaccinated, pneumonia in mid to late life is associated with an accelerated risk of developing cognitive decline and dementia. It's also associated with an increased risk of cardiovascular disease and of having metabolic disorders. And ironically, what happens is once you have those things, cardiovascular disease, cognitive decline, metabolic disorders, you're at a higher risk of getting pneumonia. So it can often be a serious respiratory, and again, I always use the word serious because I don't want you to get afraid of having a cold. Your colds are fine. I'm not worried about your cold. What I'm talking about is an infection so bad that you need medical intervention to survive it. So all these things have been associated with influenza and pneumonia for decades. And in fact, one of the best things you can do to prevent cognitive decline and dementia is get all up to date on all your vaccines. we know, I mean, the list of things that happen post-COVID is ever growing, but even if you take away long COVID, we know that there's a risk of having decreased lung function, strokes, other cardiovascular events, and an increased rate of frailty or disability. So when you're thinking about how to protect yourself, you need to be thinking not just about the here and now, but the long term. These things don't happen to everybody, but you don't get to know in advance if you're one of those people who will have these long-term health issues. They are also proportionate to severity. So the more mild your infection is, the less likely you are to have these long-term health issues. And a great way of making sure that infection is more mild is to have a recent vaccination. Now, having said that, there's been a lot of chit chat about how, is COVID destroying our immune system? Is it making us, all susceptible to all these other things like that? The data, there is an emerging data on this. So this here was a big study, a big Israeli study that showed that people even weeks to months after having had COVID, and this was sort of the 60 plus crowd, could develop new things, including cough, chest pains, hair loss, and weakness. And in younger people, there was an increased association with having like strep throat, pink eye, conjunctivitis after that. But the big caveat here is that these data were all collected in the pre-Omicron era. Because there's so little testing in this era, it is extremely difficult to determine if this still happens in the context of Omicron. So one of the things that I find incredibly frustrating is that without this good testing, I can't tell you how likely you are to have these longer term health issues arise in the Omicron era, because there's no way of knowing if you got an Omicron infection. The good news is in countries that do have slightly better monitoring than we have, it does look like the people who are living with long COVID or chronic health issues post-COVID seems to be stabilizing, and maybe some of them are even getting better. So that sort of implies that with that backbone of vaccination, the risk is getting lower, but we still don't know what it is. And of course, I mean, I know many of the people listening to this will have been touched by someone who has long COVID, and I don't want to in any way minimize that, because no matter how vaccinated you are, no matter how careful you are, it's still a risk. And people sometimes have got long COVID after their second or third infection, thinking that they were going to be okay because they'd gotten through a couple other infections. So I don't want to minimize, please don't ever think that I would minimize the terrible, devastating effects of long COVID, because it's a truly devastating disease. Again, we don't have great data to understand if there's a risk of infection post-COVID. It's certainly nothing like what we see after influenza. But in this study I was peripherally involved in the long-term care center, we looked at people who got COVID, and if they'd had COVID and a recent vaccine. Everyone had been vaccinated, but if they had a really recent one. And we did see that the people who hadn't been recently vaccinated were more likely to be prescribed antibiotics. This generally means that either their infection was a lot more severe, and so the doctor was giving them antibiotics, which to deal with maybe another bacterial infection that was occurring, or that they were getting other bacterial infections and needed antibiotics. So this is one hint that we have, that a recent vaccine makes the disease less severe, and so does protect people from these sort of add-on infections that can happen right afterwards. Now, you folks are workers and care a lot about workers, so let's talk about workers, shall we? It's actually very, very difficult to get data about the effects of COVID on the workforce. The people who have the best data tend to be people who are dealing with insurance claims for people who are off work because they're ill. A lot of that doesn't get published in the standard scientific literature. So we don't have excellent data. And what we have to do is, we have to sort of comb through data that comes from governments who are tracking these sorts of things. England, having had so many COVID infections, has also published these data showing that there's been a steep increase in working age adults who are outside of the workforce because their illness doesn't allow them to contribute to the workforce. And the belief is that this is attributable in part to long COVID, You'll see in the quote here, he speaks about this being particularly bad in women. Women are more likely to get long COVID than men. So that is believed to be one of the reasons that this has happened. Again, in Canada, our numbers are miserable. We cannot actually say what the numbers of people who are outside the workforce or have had to cut back hours or be adapted to that due to the effects of COVID. But I will say, even prior to the pandemic, the number one reason that older workers retired or left the workforce was because of either chronic health conditions for themselves or they were caregiving for someone with chronic health issues. And so when we think about all the ways the workforce has been impacted, and it's some of the more vulnerable sectors, the construction sector, the healthcare sector, many of those retirements are probably due to either health issues of someone who is dealing with the effects of a serious infection or the people who caregive for them. As well, we know that the aging population in Canada has increased medical complexity, and COVID certainly has not helped. So many of those older adults who were hospitalized are never going to return to the level of function that they had before that hospitalization. This increased medical complexity puts a strain on our primary care system, our family doctors who are already so overworked, and ironically leads to an increase in needs for the long-term care sector where COVID infections are such a huge problem. So we really need to have people who will advocate to helping prepare our healthcare system for a sicker population, which is an inevitable consequence of having had so many infections in the last 3 years. Here's another known. COVID is here forever. People, again, wanted it to be like smallpox. So smallpox is a disease that has been eradicated from the face of the earth. And this graph here just shows you when it was eradicated. The last case for smallpox was in 1977, and it was eradicated because the vaccine that we had for it, well, for two reasons, produced great high-level immunity. The second reason was it only lives in humans. So if you vaccinate all the humans, it's got nowhere to go and it dies. A major turning point in the pandemic was when, well, there were two major turning points in the pandemic. One of them was when we found it could infect animals and then come back to humans. We've never eradicated an infectious disease that has an animal reservoir because we cannot vaccinate every wild animal on the planet. So I remember that being a dark day for me early in the pandemic, realizing that this was here for us forever because we can't eradicate a disease that has reservoirs in wild animals, unfortunately. There was a time when it looked hopeful. So this was the very first clinical trial for the Pfizer vaccine that came out. And I remember the joy I felt when I saw these data early in the pandemic. The placebo group in blue was compared to the group that got the Pfizer vaccine. And effectively, after the 2 weeks it takes for a vaccine to kick in, there were virtually no infections. It is possible that if we had the political will to get the world vaccinated before we had these variants, we might have been in a place where COVID was not here with us in the way it is today. But we lost that opportunity when countries in the world allowed mass infections of their population, and when we lost the trust of the global South, who didn't have access to these vaccines. And so this hopeful time where the difference between, being vaccinated and unvaccinated was so huge has been lost. And that's another reason why we will be living with COVID for the rest of our lives. And as I mentioned earlier, we need to move our thinking and shift our thinking. You're never going to be done with your COVID vaccines. I have probably had at least 20, maybe more, 25, I don't know, influenza vaccines. And if all goes well, I'm hoping for another 40 more. We need to shift our thinking to our COVID vaccines. Vaccines come in 3-4 flavors. The useless, like HIV at the bottom there, we've never been able to make a vaccine for it, or we can make a vaccine, just doesn't protect anyone. Ones that need boosting on sort of a long-term scale, like tetanus. Ones like influenza, where you need regular intervals, and ones like the measles vaccines, where you're pretty good for life, pretty good. COVID and influenza are the same now. So you're never done, and you can stop counting. Just think about how recently you've had a vaccine, not about how many you've had. It doesn't matter. But I'm not a pessimist by nature. Otherwise, I don't know how I'd survive. The good news is that, remember I showed you those graphs about those hospitalization rates? And even though these new variants have all these scary names and they're supposed to be so immune evasive, those hospitalization rates are slowly decreasing. They're still far too high. COVID is still the #1 reason for hospitalization for people over 50. But at least they're going in the right direction. And that's because we've learned that there's 2 arms of the immune system, what we call the humoral response, which is your antibody levels, which protect us from infection and transmission, and our cellular responses, which protect us from severe hospitalization and death. Even though we cannot get those antibodies levels up as high as we need them to protect us completely from symptomatic infection, those cellular responses are doing a great job at protecting us from severe infection and hospitalization. And I actually have really high hopes for kids who are growing up in this era, because hopefully they'll be much more protected than any of us who came to this when we were already adults. So again, I'll just show you the graph to show what I was talking about. Remember, this XBB1 and this EG.5 were supposed to be completely disastrous. Well, like I said, I'm not a minimizer. These are too high. These hospitalizations mean that there are a lot of lives disrupted and a lot of people not going back to the lives they need. But they are on their way down. And so my hope, my dream, is that with continued vaccination, we can live in a world where we continue this trend and get to somewhere where we can continue to live our lives as normal. I hope. Okay, last knowing is that ageism has been a killer in this pandemic. The human aspect of how we make decisions and who we prioritize has been as much a killer as anything else, as far as I'm concerned. Canada has the dubious distinction of having the most COVID deaths in long-term care than any other OECD country. We're #1. And if that doesn't want to make you want to hang your head in shame, I don't know what will. And of course, for those of you who work in this sector, infections in the people who support the long-term care sector have also been incredibly high. And that's so unfair. And in fact, if you look on the left side of this graph here, residents of long-term care make up 0.5% of the population in Canada. But in May 2020, they made up as many deaths as the rest of the 99.5% of the population. It is appalling, and it is a source of national shame that I'm not letting anybody forget. So I'm just going to show you some data from our study, and I just want to show you how difficult it is to run a study like this. So this is our staff. At our peak, we employed 45 people across the long-term care sector and retirement sector to help us perform these studies on immunity in older adults. And we had some incredible partners in the Schlegel Villages and St. Joseph family of elder care. My co-lead is right here, Andrew Costa. Oops, sorry. Now, Andrew Costa had been working for a long time trying to understand the features of long-term care homes that made them so susceptible in Canada. And many of these features actually come down to staffing patterns. We don't pay and we don't train people in infectious disease prevention and control in our long-term center in Canada. So we have all these people who often live in COVID-19 hotspots and who are working and are also in these vulnerable populations and are working in these homes. Canada does not have good rules for ventilation or for crowding. We, at the beginning of the pandemic, we had to have mandates from different provinces to stop having 4 people per room because that was shown to be a risk factor for infection and death. And of course, we have this mix between nonprofit and for-profit, and that changes the dynamic of how these homes are set up. We also have one of the risk factors for infections was older design, and that is certainly due in part to air circulation and air ventilation, things like that. And one of the things that makes me very frustrated is the fact that we haven't really fully implemented a lot of the changes that we know are going to be really helpful in this sector. So again, you know, people expect me as an immunologist to say, just get a vaccine, you'll be fine. But there are structural features to why we have these high rates. And we need to deal with those structural features and frankly, equity issues of the people who work in these homes if we truly want to make an impact. We should not have part-time workers working in multiple homes. We should have full-time jobs within a home so we don't have people bringing infections to various homes. But if policymakers and politicians are not going to invest in these major structural things, then immunologists like me have to step up to the plate and start making use of the resources we have. One of the things we did in the pandemic is we compared Pfizer versus Moderna. So if you look on the bottom here, P1, P2 means they had 2 Pfizers. P1 to P2, P3 means they had 3 Pfizers, and then if the M1 and M2 is 2 Modernas, and then 3 Modernas, and et cetera, et cetera. In the red zone means that antibodies weren't detectable. So you don't want to be in the red zone. The blue bar means about half the people are above and about half the people are below. Moderna has more mRNA in it than Pfizer. And as a consequence, it seems to mount a stronger immune response in older adults. So if you look here, this was, I think, about 8 months after they'd had their 2 Pfizers or their 2 Modernas. Look at where the blue bars are. More of the Moderna folks were out of the red zone, and more of them had really nice high antibody responses. When we look even at the 3rd doses, again, look at all those Modernas who have hit the top of the scale there. So one of the recommendations that we made is that Moderna should be used preferentially for older adults, and in fact it is. And one of the reasons that we've been able, Canada's had slightly better infection rates than the US is we've relied so heavily on Moderna. And I have to tell you, I'm a Moderna girl myself. After seeing these data, I was really committed to making sure I got vaccinated with Moderna. Although more mRNA sometimes makes you feel a little bit more sick. So, pluses and minuses. The other thing that we did as part of our study was try to advise on when to vaccinate, because this makes a lot of sense from an immunology perspective, but wasn't totally intuitive to people who are administering the vaccines. I'll tell you this story in the context of the Delta variant, because I remember this so vividly. We just heard about Delta. There were just the first reports that it came to Canada. And we were looking at the antibody levels of our older adults, and that were about 6 to 8 months outside of their last vaccine. So here we have the green zone, which means about the same as a healthy, young person, a healthcare worker. Yellow zone in the middle, red zone, bad news. At the start of the Delta period, fully half of our participants did not have detectable antibodies in long-term care. And many of the monoclonal antibodies that are used to treat hospitalized people did not work against Delta. And I remember vividly staying up at night and worrying about what was going to happen. I remember speaking to the people who worked at the homes, and I had one of them break down into tears, and he said, if you're telling me there's going to be another wave like there has been, I can't do it. I can't. I said to my league, Andrew Costa, I called him the next morning, and I said, Andrew, I couldn't sleep. He said, Dawn, I couldn't sleep either. I said, what are we going to do? He said, we're going to call everybody. We're going to call everybody. And so we went on our publicity tour of trying to speak to any policymaker or decision maker who would listen to us. And I'll tell you the good news story in 1 second, but I'll just tell you one of my observations. We also went and did a bunch of presentations to the long-term care homes themselves. And this was a quote from one of the participants who said, you know what, I know what you're saying, but I'm healthy. I've never had the flu. I see lots of kids. I'm sure my immune system's been boosted. I don't see why I need a 3rd shot. And it became apparent to me that just presenting the science was not enough. We scientists have to become better communicators, because even our residents in long-term care who were at such high risk were getting the message that they really didn't need this, that they weren't the sick people, that somebody else needed a vaccine, but it wasn't them. Nonetheless, here's what the graph looked like. There was just starting to be an increase in infections in long-term care and retirement homes. The third doses went in, they went down to 0. And I'm going to show you the even better news. So if you look at this section here, sort of April, May, June, et cetera, you know, deaths in long-term care were actually lower than older adults living in community. The best time to get vaccinated is right at the start of a wave, because that's when you're most likely to be infected. And that's also when you're most likely, if you don't get infected, you're not going to be spreading it. So it's the only chance we have to really shorten or to blunt a wave. And so that has been a policy that has been implemented in the LTC sector in Ontario, is to really not worry so much about when people had their last vaccine or whatever, but to time these to the beginning of the waves. And that seems to have made a major difference. So I have talked for far too long, but here's your take-home messages. Take-home message 1, you can't rely on a previous infection to protect you. You need to get vaccinated this fall season. Best time to get vaccinated is at the start of the wave. In the Omicron era, that protection from symptomatic infection is short, so use it wisely over the time where you're most likely to get infected. You know, getting vaccinated in a low point is not as useful as getting vaccinated when things are looking a bit problematic. There are, of course, exceptions. You know, I always say, you know, if you're starting chemotherapy, you're starting a major immunosuppressant drug, if you're traveling, especially to part of the world where there's lots of COVID, obviously a vaccine is a great idea in advance of any of those things. Vaccination is one method of protection, but it's not the only method, and frankly, I don't think it's the best method. So we do need to think about these structural things. Vaccination is your last ditch, not your first ditch effort. And in fact, if we had many of these structural things in place, the ventilation, the filtration, policy changes in how we staff long-term care, we'd see an impact on all respiratory infections. So it's one method of protection, but we can't rely on it as our only method of protection. We don't know the long-term health effects of COVID infections. And I know I keep my mask on indoors because for me, it's just not worth the risk until I have better data to make better decisions. And I can't tell you how protected you are from these long-term effects by vaccination yet. And so we have to consider other ways to keep ourselves protected. I just want to end today by honoring some of the participants who gave the blood that provided the data that I'm sharing with you today. Also the staff of these homes who were all trained to become research coordinators and just did an incredible job. It's probably the most meaningful and important work I'll do in my career. And I'm so glad to have had interactions with these incredible people. And I have some stories here that I will pause on for you to look at during the Q&A period.
Well, thank you very much, Dr. Bowdish. This has been so informative to hear about the research behind supporting immunization, particularly in older workers. And I have to say, I really appreciate the clarity on why COVID will continue and why influenza is continuing. It's because of the animal reservoir. I appreciate that clarity. One thing that your talk made me think about was something that I heard Dr. Isaac Bowdish talk about on CBC. This is several months ago. He was talking about researchers now looking into immunizations for both influenza and COVID. Do you have any knowledge or any thoughts or updates on that?
Yes, you know, one of the things that's amazing with these mRNA vaccines is we can mix and match. So there have been some clinical trials now on influenza and COVID together, one on RSV, influenza, and COVID. And I'm really excited about this because, first of all, the mRNA vaccines have outperformed my wildest dreams in older adults. Obviously, we're still in a world where there's a lot of hospitalizations and deaths, but I have this vivid memory of long-term care starting their vaccination program. And, it was such a dark and stressful time. And I remember thinking, oh, I'm going to have to explain to the public that for older, vulnerable people, the best we can hope for, if this is like an influenza vaccine, is a fewer deaths and maybe making the disease a little bit less bad for most people. The mRNA vaccines were a game changer. And so the fact that not only can we mix and match so to make it easier and give people more protection, and ultimately at less price if they're combined, we can really help, pregnant people, medically vulnerable people, and older adults with these vaccines. It's a golden age, a really golden age for vaccinology.
Thank you very much. Now, if we take a look at some of the questions in the chat, Val, did you want to start with that?
Sure, and I want to also second your thanks. It was a very informative presentation, Dr. Bowdish, and a full range of issues that we think about, particularly as Kevin even asked in the chat about the non-pharmaceutical interventions and how important those are in workplaces and in residential homes, congregate settings, and all that, and particularly ventilation and wearing respirators in the absence of good ventilation. So thanks a lot. And I did put a few questions in, as have others, and I know I saw someone had their hand up. So, and I know you have to leave at 3, right?
Yes.
So we'll try to get through them. My first question actually was that you showed the hospitalization, and it is very like seeing the frequency of the peaks and valleys is very informative, but your reliance, or I guess not reliance, that's not maybe the best word, but the interpretation that it's getting better over time. My only question is, I understood that the case definition of COVID hospitalization was deliberately changed in different provinces at different times, and I don't know if the source of the data, or if it's corrected in the way you've done that, or if in fact it's
yeah. So politics is the thing. Politics and data are problematic. Different provinces do have different ways of presenting. I show the Government of Canada data. No data is perfect, but the reason I choose the Canadian-wide data is both to represent the whole country, but also because the way it's sort of cleaned up is mostly, fairly accurate. And, this whole hospitalized for or with COVID thing is just garbage. So if you go to the hospital with 2 problems, your outcome is always worse than if you go with 1 problem. So if you go for a broken hip, as an example, and you have COVID at the same time, you're going to stay longer statistically, you're going to stay longer in the hospital, and you're going to have more complications getting out of the hospital. So I don't care if your primary reason for visiting the hospital is because you have traditional, sick symptoms, or you have 2 things happening at the same time. 2 things are harder to treat than 1 thing. And so I don't really see the distinction. And the math is so clear, with any infection. If you go with influenza and a heart attack, or influenza and a broken hip, your outcomes are worse because your immune system is trying to fight 2 fronts at the same time, and that makes things more complicated. So having a serious infection with anything else that you might go to the hospital for makes everything but worse. So that distinction is not, I don't think there's a good reason to pull those 2 numbers apart, but the data I've shown you is hospitalizations from the Government of Canada definition of for COVID.
Have you actually tried just hospitalizations in general to see?
So that's a little bit harder to get, but yeah, because each province has them in general. So we can look at hospitalizations in general. And here's the other side of this. One of the things that I've been, really encouraging people to get vaccinated this year is because last year was an absolute disaster for the healthcare system. So to get to my office at McMaster University, I have to walk by the children's emergency room. And the lineup, there were hundreds literally hundreds of people. Every room on the first floor of that hospital had been devoted to dealing with children's infections. I've never seen anything like it. It boggles the mind. We weren't prepared for that. There were challenges with that. And then, of course, with each of these challenges to our healthcare system, we're at slightly less capacity. So all summer, if you follow the news, you will have heard about healthcare shortages, emergency rooms being closed, rural areas having to go elsewhere, things like that. This year's wave doesn't have to be as bad as last year's to be problematic.
Mm-hmm.
It could be less bad, but with less capacity, we're less able to deal with it. So, yes, the hospitalizations seem to be going down a little bit for this. That's great news. But we can't handle the hospitalizations we have. And each of those hospitalizations comes with a sad story. The older you get, the less likely you are to return to the level of health before you came to the hospital. So each of those comes with a family that has to support someone who's more frail or weaker than they were before. Each of those hospitalization comes with a story of someone who can't get into a long-term care or retirement community that provides care for them. Each of those is a sad story, and we should be trying to prevent those sad stories.
Thanks. I see, Ken, you have your hand up. Do you want to unmute and turn on your video and ask a question?
Very briefly, two things to make clear in my own mind. Number one is that the RNA vaccine does nothing to protect you from catching COVID. And number two, that the RNA vaccine does nothing to prevent you from spreading it once you've got it. Thank you.
Yeah, so this is an important question. And again, if it were easy, I could give you an easy answer, but now you're going to get a long answer because that's the truth. The vaccines do give you some protection against symptomatic infection, but not forever, for a short period of time. They also make the infection a little bit more mild, and people who've been previously infected or vaccinated shed less virus. So there's a bit of a dose effect. And there's this amazing study. It was actually done in jails, so it feels a little odd, but where they looked at people who had been vaccinated and they lived in the same cell with someone. So those people all got infected, right? Because the dose, you're breathing the same air, and then but they found that people were not infected when people lived a bit further away. So when they lived in other cells, if you're side by side with a sick person who's not wearing a mask and you're caring for them and you're intimately, in the same house, you will probably get infected unless you wear a respirator, probably. But if you're walking through a store and you breathe in a little bit of virus and you've been recently vaccinated, your chance of being protected is much higher. So it's not as simple as saying they do or do not. They do a bit for some period of time. And the thing is with infectious disease, if everyone was vaccinated at the same time and had that period of protection, we'd see a massive drop in the number of viruses around. So there's also this indirect effect as well. So there is no simple answer to your question, but to summarize all the things I've just said in a maybe a bit more succinct way, they provide some protection for a short period of time from symptomatic infection.
If I may, the dose amount makes sense for the spreading it, but it doesn't seem to, in my logic, make any sense for me getting it, preventing me from getting it, protecting me from getting it. I can understand the amount of dose that I may spread because I've got the vaccine, maybe lesser, so I'm not as easily spreading it. But I don't see how that affects me from getting it.
So for most viruses, you actually need to inhale 1,000 viruses to get sick, believe it or not. You think of it as just a virus, but you have to actually inhale 1,000 of them. And that's because, for many reasons, the virus, it can't get stuck in your snot. It has to actually get to your cells. And so there's, a little bit of a luck of the draw, I guess. And with a highly contagious virus, it's probably closer to 100, and with a less contagious virus, it's more than 10,000. But if you only inhale a little bit of virus, maybe you'll be lucky enough to only have, to have enough antibodies, enough protection to deal with a little bit of virus, but you might not have enough antibodies to deal with 1,000 viruses. So that's where that dose comes in. It's a bit esoteric because in truth, you don't get to know how much virus you've ever breathed in, right? But it's the difference between living with someone and walking through a room where an infected person just breathed.
Mhm.
Thank you.
Thank you for the question. I think you did answer in your presentation, although, and Kevin put in some links about ASHRAE and the importance of ventilation. Kevin, I don't know if you wanted to add anything else.
Yeah, I was just going to say that with your work, Dr. Bowdish, fabulous presentation, really clearly explained. I loved it. Thanks so much. But kind of prioritizing to long-term care homes, we have a wonderful opportunity now. There's a brand new standard, ASHRAE 241, control of infectious aerosols, and I'm just thinking like it could be prioritized to these vulnerable groups of vulnerable people. And why not just really push it hard with long-term care homes? I just see there's a great opportunity now for that.
I think you are absolutely right. Like Canada, I share that embarrassing data about us having the highest rates of COVID deaths in OECD. We have the highest rate of respiratory infection deaths. Forget COVID, RSV, seasonal coronaviruses, all these other things. And, one of the lovely things about caring about the air is it applies to all those viruses, right? It's not just COVID. And so why wouldn't we take this as an opportunity to be a leader in this field and to protect our vulnerable older adults from everything? And, I think we've learned a little bit about crowding, and that's lovely, but, we still have so many of these outbreaks that could be prevented by just a little bit more context. If this had been an influenza pandemic, and we had to rely on vaccines that worked like our normal seasonal influenza vaccines, we would have been better off vaccinating all the people around the long-term care residents, because those vaccines really don't work very well in that population, and putting in HEPA filters in every room. So, ironically, vaccines are cheap and easy compared to structural features, right? And they put the responsibility on the person, not the builder. And people expect me as an immunologist to be rah vaccines, but they're the last thing that a vulnerable person should be relying on. And the first thing should be these other more broad features to make their lives better. And so, I'm fully supportive, and I find it frustrating that policymakers and politicians want to go with like cheap and easy as opposed to meaningfully, structurally changing our LTC sector.
Just thanks for that. Just so with the new standard, basically they talk about infection risk management mode and using that as a deciding factor. And now we're talking about like vulnerable people. So really that should be incorporated into that. And I just think, we're all trying to advocate for change. And I guess with your knowledge and your influence, then hopefully together we can kind of push this a bit stronger. So thank you very much.
I sure hope so, because there's an infectious disease. The other thing is too, we need to advocate for more testing too. So, one of the things, we have this new RSV vaccine for long-term care in Ontario, which is amazing. I couldn't be happier. But there's a little pushback because it was like, well, how much RSV do we actually have in this sector? And if you don't test people, like during the COVID pandemic, everyone only got a COVID test. They didn't get an RSV test. They didn't get an influenza. They didn't get a seasonal coronavirus. They didn't get an adenovirus. So we didn't have the data to say this is how many infections there are. And so without data, it's easy to pretend there's not a problem. So there's also, I think it makes a lot of sense to advocate to understand how big the risk is for these infections as well, so that we can say that invest in these vaccines for this population, and frankly, for the people who work there. I mean, I'm happy that we're starting with the residents of LTC for RSV, but we should also be focusing on their grandkids, who are going to be the people who give them RSV, and the people who work in these homes who inevitably will be bringing in viruses that don't make them very sick.
Thanks. I had a couple other questions, and I don't know, both Kimberly and I just put in the information about our event starting at the end of the month on OCC disease prevention in general. Kimberly's got more information. The two questions I wanted to ask are, well, about immune suppression in terms of other infections resulting from COVID, and you showed that actually from the flu and from pneumonia. There's a long-term pattern, but also that wave we saw last fall. I believe, or I feel like I've seen that there's some correlation to COVID infection in some of the children spiking RSV infections, and then the severity as well. So there's the getting it, and then it's how severely it impacts. I don't know if you have anything.
Yeah, it's really, really hard to know, because most of the, say a kid goes to the hospital with RSV, did they have COVID in the last 6 months? Well, did they have a rapid test? Did they, it's really hard to collect that data in this era. I think, and of course, nothing's ever easy. So I think what was probably happening last fall was everything was happening all at once. One of the things that we have had is a huge drop in pregnant women getting vaccinated for everything. And in some jurisdictions, there were a lot of babies being admitted with either COVID or influenza who were less than 6 months old. Hypothetically, those babies would have been protected had mom been vaccinated. So some of it was falling vaccination rates in pregnant women. Some of it was lack of exposure to RSV previously, because generally if it's going to go south for a kid, it's their first exposure. So there was sort of like a double cohort of kids who hadn't been exposed. Some of it was the fact that everything was circulating at the same time, and co-infections end up being worse. So, and kids are famous for co-infections. So they don't just get flu, they get flu and RSV, or they get COVID and influenza, they get things at the same time. And so some of it was likely that. Like I said, there's this Israeli study that suggests there might be a relationship between COVID and strep throat and conjunctivitis. So maybe some of that was that. But there isn't really strong data saying COVID was a driver of all these other things. Whether that's because there was no testing or whether because it wasn't that, I don't know yet. And I remain agnostic, because COVID is a weird virus in many ways. A lot of these, the Gustav Klimt death due to the pneumonia is due to the fact that influenza causes what's called a type 1 interferon response, and that makes you weak to pneumonia. COVID doesn't do that. So one of the reasons we don't think there's been as many bacterial infections is because it doesn't have the same properties as influenza. So honestly, I don't know why it all went south last year. And this year in Australia, because we always look at them first, they had a huge pediatric jump in influenza and RSV very early, but then it got back to normal levels. So I don't know what the answer is. And I think, like all these things, it's more than one thing happened at the same time. And so teasing those things apart, I think, is really important, because it helps us make better decisions about what next year is going to look like and the year after that, and that sort of thing.
You made the comment, and I wrote in, you made the comment about being optimistic with respect to young people and future, and, on the basis that the lines are getting smaller and smaller, the hospitalization line, the severity, then hopefully we think. But I guess, was that based on regular vaccination of youth, or was that based on regular infection of youth, and eventually it'll get better for the people that survive? Or I guess
yeah. So get your kids vaccinated, full stop. In the pre-Omicron era, it is true that kids, when they did have a problematic infection, it was catastrophic, but it was rare. In the Omicron era, COVID has killed more kids than influenza, and there isn't a pediatrician on the planet who doesn't say influenza. So I'm not saying kids are fine and everything's fine and you should just let them get sick as many times as they want. Everyone should have a backbone of vaccination to protect them. But kids are different than adults, which is why we study kids and old people separately. And they tend to have longer responses, and their immune system has a bit more plasticity. And so it is possible, there is no data to support what I'm going to say, but it is possible that they get their vaccine, they get their early exposure, and they handle them better forevermore. And then it's not till they get really old that they get. It'll take us 40 years to know if that's true, but it is possible. And one hopes that that is the case, because like I said, COVID's going to be with us forever. So my hope is that COVID vaccinations will get wrapped up into the childhood vaccination schedules, because we're really good at vaccinating kids because we all go to the doctor at the same time and we all bring our kids in, and if it's in the doctor office, people feel safe about it. So my hope is it'll get wrapped into our childhood vaccination schedules and our pregnancy update schedules. And then those kids will have a much better background to deal with whatever comes next than those of us who are older and, you know, saw this for the first time.
Thank you. I see that we're now at 3 o'clock and you have to run. I want to say thank you from the bottom of my heart. This was fantastic. And Val, I'll let you have the last word.
Oh, well, no, I could keep talking all day. So, but yes, we all need to go. We have put the information in the chat. We really appreciate everybody's time and sharing your afternoon with us every month roughly now for these Occ-COVID conversations, because we are all in this together trying to prevent transmission in workplaces and then transmission in homes and schools and long-term care and other places. And yes, we really appreciate Cheryl, you for hosting today, and Dr. Bowdish for sharing your time with us and your knowledge. So thanks again. And as we've put in the chat, we start again on October 27th. We'll have a 5-week series on occupational disease and illness prevention we call October. And we look forward to seeing everybody then. And we'll start again, and our next Occ-COVID conversation will be at the beginning of December. So unless it's all gone by then, but you've told us it won't be. So we'll be back here again in December. Thanks again, everybody, and have a healthy and safe and fun long weekend. And happy Thanksgiving. Bye-bye.